Hey guys, John here with NRSNG.com and NursingStudentBooks.com. Thank you so much for visiting, for checking out this video. Today I want to talk to you about creatinine. Okay, in a recent video we just covered what BUN was. Today we're going to cover basically what creatinine is. If you haven't had a chance to watch that BUN video, it might be helpful in understanding the difference and how these two play in together. I also want to let you guys know about our new app that's coming out, RN Crush. If you go to rncrush.com, you can learn more about that. It is a mobile app for nursing students to help them study for NCLEX, but it is developed as a game, so it's very different from what's out there, and it's a great way to help you prepare without stressing about studying and things like that. Alright, so today, like I said, we're going to talk about creatinine. What is creatinine? Well, like I said, we just talked about what BUN was, so let's dive right into what creatinine is. Creatinine is a byproduct of something called creatine. Now, certainly you've heard of creatine. Creatine is produced in the liver primarily, and it is used in our muscle tissue. Basically, it plays a role in ATP formation during muscular effort. So think of creatine as contributing to ATP to help our muscles with these quick bursts of energy that they need. Now, when that creatine has been used, what happens is it becomes converted into creatinine. Okay, so creatinine is the byproduct of creatine, and this creatinine is not used by the body. It needs to be taken out of the body. We have to get rid of this creatinine. We have to dump it out. We have to throw it in the garbage. Okay, so the way that we throw that in the garbage is it travels through the bloodstream to the kidney. Alright, let's pretend that's a kidney. Okay, and within the kidney we know that inside the kidneys we have these little glomeruli. And the glomeruli are those little ball-shaped structures in the pyramids. And what these glomeruli do is as the creatinine comes in, that creatinine is filtered out in those glomeruli, and it is taken into the ureters and becomes excreted in the urine. Okay? So, let's walk through this one more time really quick. Creatine is used by the muscles, and it helps in ATP. When we've used up that creatine, it becomes creatinine. That creatinine travels through the bloodstream into the glomeruli, and the glomeruli filter that out and dump it, okay, in our urine. So, because it's filtered through the glomeruli, it's actually filtered at a very high percentage, or another way to say that would be it's not reabsorbed, or very, very, very little of it becomes reabsorbed. So creatinine we actually try to get rid of entirely from our body, and we do that through our glomeruli. So one number that we will look at to determine how well our kidneys are able to excrete creatinine is going to be GFR, okay, glomerular filtration rate, and that's a number that we oftentimes use to kind of determine renal function, because that number is going to, in a large way, tell us how much the kidneys are able to excrete creatinine. Okay, so the number that we're looking for, optimal number, would be 100. Okay, we really want our patients to be greater than 60. Number around 60 would indicate stage 1 to stage 2 CKD, kidney disease, and that's according to renal.org. Okay, if we have a number between 30 to 59, that's going to indicate stage 3 kidney disease. Whoops. And if our number is less than 30, that's going to indicate stage 4. Whoops, how do you write 4 like that? Yeah, 4 to 5 kidney disease. Okay, so does that make sense? I hope that makes sense. So creatinine is excreted from the body in the kidneys, but more specifically, it's filtered out in the glomeruli. So we can use GFR, glomerular filtration rate, as an indicator of how well the kidneys are filtering that out. And we're hoping for a number between 100 and 60. That number can decrease with age. Okay? And then another indicator that we can use is we can look at the lab value creatinine clearance. And the way they do that is they look at urine creatinine and they look at serum creatinine. And by looking at those two numbers, how much is in the urine versus how much is in the blood, they can kind of take that number and come up with what's called creatinine clearance. And that's another way of them saying, okay, there's all this creatinine in the blood, and there's only this much in the urine. So we know that the body's not able to get rid of that creatinine, and that could give them a good idea of kidney disease as well. Okay? Now let's talk about how BUN and creatinine are related. So we have our BUN and we have our creatinine. Okay? Both BUN and creatinine are nitrogenous waste products. Okay? So basically, BUN is the breakdown product of protein. Okay? So we'll say it's protein broken down in the liver. And then creatinine is the breakdown product of creatine in the muscles. Okay? And they're both sent to the kidneys. And what happens here is in the kidneys, BUN can actually be reabsorbed in states of hypoperfusion. So if our kidneys sense that they're not getting enough blood flow, they're going to reabsorb some of that BUN, that urea nitrogen, that urea. But the difference here is that creatinine cannot be reabsorbed. The glomeruli, their job is to completely rid the body of creatinine, basically. And that's why our normal value for creatinine is so low. Our normal value is 0.6 to 1.2 milligrams per deciliter. Okay, and our BUN is going to be about 10 times that number. It's going to be 10 to 20 times our number for creatinine. Okay, and so with that in mind, with the fact in mind that BUN can be reabsorbed and creatinine cannot, let's move on to the next subtopic here. And so like I said, the normal number, the normal ratio of BUN to creatinine is about 10 to 1 to 20 to 1. Okay, that number is called our BUN creatinine ratio. Okay, now why would this number be useful? Okay, it all comes down to the fact that BUN is reabsorbed, creatinine is not. Okay, so because of that, and like I just said, because BUN can be reabsorbed in states of hypoperfusion, we look at our BUN creatinine ratio to say, okay, well, the patient has a really high BUN. Instead of jumping to the conclusion that that patient might be in renal failure, we look at the BUN to creatinine ratio. And in an instance where BUN is high but they have a normal creatinine, that would be instances like volume depletion. Okay? So essentially an increased ratio, it means decreased blood flow to the kidneys. Okay? So let's say we have an increased BUN to creatinine ratio. Okay, let's say our number is 30 to 1 or whatever. Okay, so if our number were something like 30 to 1, that's going to tell us that we have decreased blood flow to the kidneys. Okay, this would occur in situations like CHF. Okay, we're not perfusing our body, we're not perfusing our kidneys. Okay, so our BUN is getting reabsorbed, but we're still losing that creatinine. Situations like dehydration, increased protein, and GI bleed. So your doctors are going to be really smart about this. They're going to look at the BUN, they're going to look at the creatinine, and instead of jumping to any sort of conclusion, they're going to say, okay, first of all, let's look at our BUN creatinine ratio, let's look at our other signs, because they might not be able to see. This is a way that they could possibly catch these disease processes early. They would get them advanced rather than waiting until the signs of these would all set in. Okay, so in an instance with elevated BUN creatinine ratio, we're talking about volume depletion type issues. Okay? Now, when would we have a decreased BUN to creat ratio? Okay? Let's think about that. So BUN is, this urea nitrogen is basically formed in the liver. Okay? So what types of diseases would cause our BUN to creatinine ratio to go down? Let's say it goes down to 7:1. Okay, think about it. What would cause some of those issues? Okay, things that would cause that are going to be things like liver disease. Okay, malnutrition. Malnutrition, like decreased protein. Okay, so remember, BUN is a byproduct of protein metabolism. So if our protein metabolism is down, then protein metabolism occurs in the liver. So if our liver is not able to metabolize protein, it's not going to be creating this BUN. Okay, so because of that, we're going to have a decreased BUN to creatinine ratio because our creatinine is still doing everything that it should be doing. Basically, it's being created in the muscles, tissue, and being taken to the glomeruli and being excreted as it should. So it's going to continue to go up. However, our BUN is not. Or situations of malnutrition, decreased protein intake. If we're not having the protein coming in, the liver has nothing to, it has no reason to create this urea, nitrogen. So it's not going to create that, and because of that, our BUN is going to decrease. Okay, so it's important to not just look at one number or the other, but to look at this BUN creatinine ratio and think through the process. BUN is a byproduct of protein metabolism, occurs in the liver, and it can be reabsorbed. Creatinine, on the other hand, it's a byproduct of creatine breakdown, occurs in the muscle, and it cannot be reabsorbed. Okay, so that's really basically it with BUN creatinine. That's kind of what you need to know. If you want to reach out to me, contact me at contact@nrsng.com. Be sure to check out our new app, RN Crush. You can find that at rncrush.com. And we are the premium seller, or the premium creator, I should say, of nursing student books up on Amazon. We generally have 10 to 12 books that are ranked in the #1 or on the top 20 for nursing books on Amazon. Find those at nursingstudentbooks.com. We oftentimes have promotions going and things, but I'd love to hear from you guys. I'd love you to reach out to us. Be sure to check out the blog, nrsng.com. Sign up for an email list on there. You can get a free EKG chart. But that's the best way to stay in touch with us. We have so many new things coming out almost every single day for you guys. So thank you.